Good morning. I would like to get started by thank you, the organizer, for giving me the opportunity to talk today. Slide, please. So I've been asked to tackle the issue about adherence and kind of intimidated to follow after Carlos. So this is, in fact, Carlos did somewhat help me in my talk. So this is my outline. I'm going to talk about adherence, what we know today about HIV treatment. I'm going to tackle the issue about resistance. I'm going to try to look at adherence in the context of TASP, which is the topic of this meeting, and try to go through some evidence-based intervention that are out there, and then kind of close with future research. So this is some data, basically seminal data. You still remember the Patterson seminal paper. We follow up that paper with, Patterson used unboosted. We use nowadays NNRTI-based heart. And we did confirm basically a very nice dose-response relationship between level of adherence and virological suppression. Just one thing, there is no issue about threshold. So the more you take, the better you off. So this is very nice to see. And in fact, other investigators just show that all regimens are not equal. Again, unboosted, the threshold of 95 was clear here, but when you look at nowadays regimen, NNRTI or PI, there's no issue about threshold. The much you take, the better. So we show it improves virological suppression, the adherence, but also it predicts survival. This is again data from South Africa showing a very nice dose response by baseline CD4. The folks who are very sick, obviously it's a matter for life and death. The folks with high CD4 count is still matter, but not as the ones that are sick. And we did follow up beyond viral load, beyond survival. We did document a quite nice also dose response with healthcare cost. As you can see on this slide, the quartile, the first quartile is the people who are poorly adherent. The fourth quartile is people who are highly adherent. Folks who are highly adherent, they have overall lower hospitalization costs, and also, but that is depend mostly on cost of hospitalization, which dramatically goes down as you move to high adherence. And even if the folks who are highly adherent, they take more medicine, so the medicine costs increase, it does not offset the benefit from cost of hospitalization. So quite very nice also to document. How about resistance? We learned that it's not a linear relationship. This is kind of a bell-shaped curve. There is enormous land where the antiretroviral pressure just facilitate drug resistance. At above of the spectrum, the beta, obviously you need to be on the right spectrum. The left spectrum, it does not bring resistance, but the disease progresses and you die. It's a bit more complex than that. David Bangsberg did show that depending on the class of drug you use, the relationship is even a little bit complex. The most important here, NNRTI, seems to be the most vulnerable, as shown on this slide. And this matter, especially in developing country where you have stockout drug interruption, because of the half-life long of NNRTI, there is a tail which, if it's not protected, you get emergence of resistance quite quickly. And this has been shown data from Uganda that missed dose, majority of them are likely to be drug interruption. So how about TASP? Well, TASP, we all rely on HPTN 052 from Mike Cohen. Some people tend to forget that, in fact, data from Mike Cohen, to get this result, they have to prove their proof of concept. And to do that, folks who are in an immediate harm, if you have some lapse on adherence, there was a very intense adherence intervention that was going on to keep really people suppressed. So at the end of the day, they can show that treatment is prevention. So this was not really, is something that we may not be able to realize in real life. And this is the real life. This is a slide from Christine. She did give me, comparing data, whether you are in France, or in US or in Africa, the cascade is far from perfect. So we need to do something about this. And data from Edmil and myself and other colleagues, we show that whether you are in developed country or developing country, we don't have optimal adherence. It may be a little bit in developing country better, but as people move over time, we're experiencing really lapse in adherence, even in Africa. So, and that was in general population. We have even emerging worrying data that in pregnant women, so this is a kind of a special population, especially in context where we're talking about B+ option, that did worry us. This is a meta-analysis of more than 51 study showing that only 73% of pregnant women achieve optimal adherence, defined as adherence more than 80%. If you try to go a bit in detail, it did worry us that this adherence even lapsed terribly in postpartum. This is really amazing, because this is women with their baby. You expect the motivation because of the baby will be high to take the medicine. They face enormous pressure, enormous stress, and a lot of problem, which just make them not adherent at all. And not surprising, you see heart compared to single-dose nevirapine or zidovudine did even have worse data on adherence. So this is emerging also result from Uganda, showing that people who start to start early, so CD4 above 250, they tend to interrupt their treatment. So this is a group with David Bangsberg, which also show that as we move toward test and treat, we need really to keep vigilant in terms of drug interruption and overall non-adherence. Why people are non-adherent? This slide just show you the most of universal reason for non-adherence, but I want to point out that in developing country, structural issues tend to dominate most of the time. You know, transport to clinic and employment, food security, lack of social support in some settings, stigma, and stock out are major issue in resource-limited setting. So what can we do about all this? Well, we need to be evidence-based, and this is, don't want to really to be biased here, but this is the best evidence so far been published to try to solve this issue. A group of convened by AIRPAC led by Melanie Thompson and colleague, we try to look at how to address this problem. Those are a recommendation we base on a huge comprehensive CDC database, more than 40,000 citation, and which we use Newcastle Tower criteria for review, and also really independent grading by experts. In terms of art strategy, some of the recommendations, by the way, this is were published in 2012. We try to update them soon, and Julio is, I think, the chair of this new panel. It was clear that in terms of art strategy, once daily regimen, which are more use favor now in terms of improving adherence to patient. Some may be familiar with this, at least those from US, very popular co-formulation of, so this is the way to go. Basically, from the Vancouver conference, we come from a long way in terms of regimen simplification. So nowadays, with one single tablet regimen once a day, really this is a major, huge advance compared to long time ago. What are the evidence whether this is making a difference? We also just published in CID updated data from Parented, data published in 2009, which basically confirm even much nicer that fixed dose combination, single tablet regimen or simplification improve adherence, not only in art naive, but also in art experience, especially those ones who are failing and struggling with their medicine. Even nicer, we just demonstrate that in terms of pill burden, the lower the pill burden, the better the adherence, and even the better the virological suppression. What was really quite interesting also, as the follow-up time increased from 48 to 96 weeks, which is our most timeline for most RCT nowadays, adherence decrease over time, but decrease less with once daily regimen. So those are the cycle in orange. Those are once daily. The blue are twice daily regimen. So how to, in terms of tool of patient, the best evidence we have so far is cell phone. I will tell you, my grandma in village in Africa, she has a cell phone, so this is a very popular tool. It costs nothing. And this is a time to use it for the benefit of health. You still remember Wall Street Gecko? We moved from there to really a small phone that are really easy to take. This is recent data just published in PLOS showing basically it makes a difference. The pool benefit is in favor of text messages. But I have to tell you, not all text messages. They have to be less frequent, they have to be interactive, they have to be personalized to the patient, and they have to be matched to the dosing of the heart regimen. You see in this meta-analysis just been published, only 2 studies stand out, and those are studies for Richard Lester from UBC, and the other one is POPLH. Those both were conducted in Kenya, so this is the 2 major RCT that are driving that PLOS pool out adherence. How about counseling? Obviously, needless to say, this is making a difference. One-to-one education, one-to-one adherence support, group education counseling. This has been solidified and confirmed in a major randomized trial from Kenya with Michael Chang and published in PLOS, which also you can find the reference. How about health system? Health system is a big issue, especially in a resource-limited setting. As we move into task shifting, nurse, community, health worker are of benefit, case management as well, but also medication management. So far, we don't recommend direct observed therapy, at least in general population. Special population, this is a big issue, especially in both worlds. Substance abuse, I think methadone to opioid dependent is important. This is the only population where directly administered antiretroviral therapy is well documented, and it came with quite strong recommendation. Integration of DART in methadone maintenance program. Mental health, a very emerging issue. We have quite strong evidence screening, management, and treatment make a difference. In incarceration, prisoner, DART as well here was useful, as well as in homeless case management, or in people, elderly people, pillbox organizer. Pregnant women, I have to confess that we did not have much evidence. In fact, with the new guideline, we're going to have much more, because there is ongoing RCT evaluating, for example, male involvement or mobile phone, which is going to help us to update this guideline in pregnant women. But so far, we did not have much other than from Jeff Stringer in Zambia, showing that awareness of HIV testing or labor ward-based PMTCT adherence services are making a difference. Children and adolescents, also in an area where we did not have much data, and as you see, most of the strength, the quality of the data we had were very poor, with only a bit type of recommendation. But again, with the new guideline, we hope to have more. So this is data from Ed Mill and the Adherence Trial Collaboration Group, which I chair. We just finished a network meta-analysis. This is an imaging technique to try to look at comparative effectiveness. This was looked in Africa and showing basically that adherence and viral suppression, the only tool that is making a difference are enhanced counseling, text messages, and treatment support at treatment body. So monitoring, we don't have a gold standard as for retention, but self-report from pharmacy refill seems to come out. Emerging technique like monitoring real time, this white pill is still under investigation in terms of operationalization, but also cost is still an issue. So what the future holds, I think we need more study, comparative study, long-term study with novel and simple intervention, incentive, P4P is being investigated in HPT 065. We need more cost-effectiveness data to guide policy. We need more data on implementation and dissemination of intervention, and this is underway. So in conclusion, early out treatment adherence may be challenging in a context of TASP in a real world. However, a 4M to implement TASP should move forward. I think that is clear. There will be need to monitor adherence and use targeted and effective intervention to optimize long-term adherence and minimize drug resistance. SMS, if done correctly, such as weekly, interactive, and linked to supportive services are effective. Once daily regimen simplification is going to be important. So I'm going to stop there and just thank all my collaborators and also the support from funding agency. Thank you.